How you guys doing so far? Is this what you expected? All right, you are going to walk out of here at the end of the last day completely full of information and recharged and ready to go back and do the best that you can possibly do where you work. It hasn't been putting this together. I'm always amazed at the amount of information that we're all supposed to know in what we do. It is really quite remarkable. It's whole books worth of things that we're supposed to know. But we do, and we're very good at what we do. What we're going to talk about now is drugs. We're going to do drugs. And one of the things that we do quite well, we can do well, there's certain areas we can do better, is using drugs for our patients. So let's talk about analgesia and sedation. So that's sort of our half hour we have together. One thing about analgesia is that pain, think about it. If you pull charts just in the course of a day, or if you look at your screen if you're on your computer of what the people waiting in the waiting room, pain accounts for the vast majority of why people come to see us. Acute painful conditions, chronic painful problems, things that pain is a huge part of what we do. And the Joint Commission notwithstanding, even EMTALA considers pain an emergency condition. So it's something we have to be able to address. It's crucial for us to be able to do this. And it has this little bit of an overlay of we have the drugs, they know we have the drugs, there's that a little bit of a tension that goes with that. I really want you to leave here getting rid of that tension. Getting rid of that sort of stress of, oh, are they seeking drugs? Get rid of that and kind of rethink about how you approach pain. And we'll talk a smidge about that as we go through it. Because your goal, honestly, if you have ever been someone with a painful condition, chronic or acute, and you've ever gone and had to justify yourself to get pain medicines, that is pathetic. That is ridiculous. We can certainly make people feel better. So early relief and effective relief of pain is our goal. So that's kind of that's the best approach to medicine, without question. And one of the other things to know about it is that just ditzel doses of things, oh, I'll give you a little bit, that doesn't work. You have to break the pain cycle. You've got to get right on top of that pain, get it controlled, and then the lower doses can keep somebody there. So don't think you can kind of ditzel your way along and get them to feel better. You really have to get it under control. So our job, and we can do this. They have the pain, we have the drugs, we can absolutely do this. One of the things in the literature that is crystal clear and absolutely mortifying is that we undertreat pain. There's Brunhilde, the nurse, who will not let go of the morphine. I don't get it. The literature says that we undertreat pain, particularly in groups that are either underserved, sort of the minority patient populations, people of color, elderly, the very young. We undertreat it, and paper after paper after paper says we do that. We know we do that. It's really clear. So our goal is to not do that anymore. Beware that we do that, and then unfocus on that. I'm going to, hold back the pain medicines. Go for it. There's no blood test for pain. I'm going to send a pain level on you. So send it to the lab. How many milligrams per deciliter? There's no such thing. So we have to kind of trust the patient and what they tell us, which means that we need some way to get a gauge of how they're doing. The pain score, which is that sixth vital sign, it's on the charts. It's something we're supposed to address. And actually, you're getting measured on this. If you don't have somebody going home with a lower pain score or an explanation of why it's not lower, you're going to get dinged. Now, I think we're focusing on the wrong thing here. I don't want a number. What I want is a patient who's comfortable. I think it's all these pain score things, whatever. That's a way that some commission can look at me and say I'm doing my job. What I really want to do is be able to go to the patient and say, how you doing? How's your pain? A lot of pain, a little pain, it's a lot better, it's a little better. Help me here so I can help you. The key is just to start the conversation. And if you want to use a pain score, great. And that's fine because it can be measured. The reality is it's you and a patient talking to them. So ask about it. It's a wonderful way, and Rick mentioned this earlier, to introduce yourself. Hi, I'm Dr. Birnbaumer. I'm here to take care of you today. How you doing? Ooh, that shoulder looks really painful. Would you like something for pain? Offer it up front. That way they don't have to beg. They don't have to ask you. You offer it up front. And if they say no, give them permission to change their mind. Really, I have something I can help you with. Okay, if you don't want it, that's fine. But really, if you change your mind, flag me down, flag down your nurse. We'll take care of that. And if the patient declines pain medicine, which is completely fine, it's not that the patient is refusing. The patient is declining. You've offered something, they're declining it. It's a negotiation. If they want it later, great. It just takes all of that sort of ramped up tension that we have about it and just gets rid of it. Just gets rid of it completely. Gives them permission. You can give them the drugs. It's wonderful. Now remember, it's not all drugs. We tend to think of treating pain as going to this pharmacopoeia, and the reality is, in the emergency department, you often need to go to the pharmacopoeia, but there are other things you can do that are wonderful helps, adjuncts for treating someone's pain. Distraction. Put somebody on their iPod and have them listen to music. That is an amazing distraction. Have a kid watch a DVD. It works beautifully. Acupuncture. I watched an entire surgical procedure, open surgical procedure performed under acupuncture as the only analgesic and the only sedative. Remarkable. Acupuncture works. Visualization. I watched an LP get done in a little girl who was terrified, 8 years old, absolutely terrified of the procedure. In addition to the local she was getting on her back, her abuela, her grandmother, took her on a story. They walked through her favorite park, and they talked about the playground area and the sand and the pretty flowers, and this little girl and her grandmother basically visualized a walk through a park, and the child didn't even notice she was getting a spinal tap. So those things are very, very helpful. Vibration. There's a reason that your dentist grabs your cheek and shakes it for all it's worth while they inject your local anesthetic. And if they don't, go back and tell them to do it. What they're doing is working on the gate theory of pain. If you block one part of it, you don't get as much pain sensation through. All those neurotransmitters can't get there. It works great, so consider it. You're injecting something, you're doing a regional block for somebody who has an abscess. Jiggle their skin nearby. It's going to hurt less. It does. That's actually physiology. That your body does that for you. Ice, beautiful. Wrap it in a towel, take those frozen peas at home, take your thing you break in the ER, put it on. It works great. Helps people's pain. Elevating it takes that throbbing away. And then you could go to drugs. So don't forget those other things. They're really powerful. But then you can go to drugs. And it doesn't mean something out of your pyxis. You can actually put something just locally in the skin. Do a local injection. If you are an excellent practitioner, if somebody comes in with the tip of their finger cut off because they smashed it in a door, you do a really good exam, and you do a digital block before you send them to get their x-ray. How fabulous are you if you do that? Local anesthetics and digital blocks are wonderful. Use them liberally. Do your good exam first, because it kind of messes it up as far as neurologic stuff, but please use that. As part of a pain-free ED is to use these sorts of things. And then don't forget injecting joints. Shoulders are great for this. If you work at a place where you see a lot of people with knee injuries near a ski resort, when you are evaluating that knee, consider locally injecting that with lidocaine. They feel much better. Better yet, use something like Marcaine that lasts longer, something that lasts a long time. So remember, all of these things short of the big drugs all work great. They all work great, and add them. They're an adjunct for pain. They work wonderfully. And those adjuncts are part of this World Health Organization analgesia ladder. If you kind of look at this ladder, it's in your book. What you'll notice on that sort of bottom mild pain range is basically just a non-opioid something and some of those adjuncts we were just talking about. But you get to mild to moderate, you start to ramp that pain up. Guess what comes in there? Opioids. I want you to remember, opioids work. We'll get into it in a second. They work beautifully. And when that pain isn't being controlled with the easy stuff, why hold back? If they're having particularly an acutely painful episode, go for it. Absolutely go for it. It's miserable. And then you ramp it up as you go from there. When you pick a drug, so now we're sort of into I'm going to go to my pyxis. I'm going to go pull out some sort of drug. Couple of things you need. I'll tell you it is, we have an amazingly rich pharmacopoeia of things we can choose from to treat someone's pain. So you get to be the chooser. You get to pick what you want from that agent. What route of administration? Is it something that oral is fine? Do you want to go IV? Is an IV a problem? Is IM what you need? Sub-Q even works in some of these agents. How quickly do you want it to kick in? How long do you want it to last? Is there anybody you can't use this in? Is this a person where we just really don't want to use that particular drug? And what are the side effects? You can pick this. I'll tell you, being a medical practitioner is pretty amazing. And when it comes to pharmacology and what we get to choose, it is so fun to pick the right medicine for the right situation. And analgesia is a great place to do this. One of the drugs that works very well, that kind of gets short shrift, is acetaminophen. We undermined the efficacy of acetaminophen by putting it in 1,000 pill bottles and putting it on the shelf of Costco. If a patient can buy their own drug in the pharmacy, it doesn't work as well. It loses efficacy, which is a shame because when it's tested in the literature, Acetaminophen, when it's used as a comparator to other agents, is pretty darn good. It actually works very well. It's not perfect, has a nice duration of action, 4 to 6 hours. It's not perfect. It doesn't work great for inflammatory pain. It works all right. Doesn't work as well as other agents might. But for just your run-of-the-mill osteoarthritis, for instance, it works great. A mild headache, it works wonderfully. We just don't think about it because anyone can buy it in the drugstore. The other thing about it is that it's gotten a little bit of bad press. One of the things that's kind of come to bear is that they feel the need to limit the dosing of acetaminophen because it can potentially hurt your liver. The reality is, in the doses that we use, if you use it appropriately for pain, it's not going to hurt anybody's liver unless your liver is already coughing its last, or you are so malnourished that you have problems with the metabolism of acetaminophen. Overall, it is an incredibly safe drug, remarkably safe drug, and it's really worth thinking about. I'll tell you, the hardest part about prescribing acetaminophen is you have to be a cheerleader. You really have to talk it up. And the best way, I think, to talk this up, especially in people with things like osteoarthritis, where it really is a very good agent for them, is to say, you know, acetaminophen comes in that sort of regular strength, but you need extra strength. You need the really good stuff. So you go out and get that extra strength pill. So they actually have some sort of salesmanship to use this because it is an excellent agent. It works very, very well. Now, nonsteroidals we use a lot, and I have to tell you, I should probably go to a 12-step program. I love ibuprofen personally. I think it is fantastic. It works for everything. And actually, nonsteroidals are wonderful. However, you have to understand nonsteroidals. They treat pain, and they treat pain in their smaller doses. What you get as an extra bang for your buck is they treat inflammatory conditions as well, but you need higher doses to do that. When you rob Peter to pay Paul, you end up paying a price. The side effects go up with those increasing doses. So know that and I'll tell you, acetaminophen is remarkably safe. Nonsteroidals start to get into the area where you can do some harm if you prescribe these to the wrong person. For instance, somebody with terrible congestive heart failure or really brittle blood pressure, what nonsteroidals will do is cause you to retain salt. Well, now I take somebody whose congestive heart failure is already a little bit borderline, give them a nonsteroidal thinking I'm going to make them better, and I have them retain salt and go into heart failure. Or GI bleeding, which is a big problem with nonsteroidals. It's a potentially life-threatening problem with nonsteroidals. So know if somebody has a history of GI bleeding, bad heart failure, bad hypertension, they're already taking something like aspirin or Coumadin or something that's affecting their bleeding cascade, because this will also increase the risk of bleeding, affects platelets, you may want to stay away from the nonsteroidals. That being said, it's a pretty good drug, and it's an excellent class of drugs for hollow viscous pain, particularly your gallbladder and your kidneys. Wonderful choice of drugs for that. Fantastic choice for that group. Now, there is a nonsteroidal that sort of has fallen off the map that I want to put back on the map, which is aspirin. Aspirin has been relegated to cardiovascular disease. Aspirin now is something we think about as a cardiovascular drug. We've kind of forgotten that it's a wonderful pain medicine. It's a nonsteroidal, it affects your platelets, does all that jazz, but it's a wonderful pain medicine. Please remember that aspirin works. In some of the older patients that you take care of, aspirin was the only medicine, 50 or 60 years ago, will use it all the time, and they're right. Now, you don't want to use it in little kids. Rise syndrome is a true problem. It's a real deal. You don't want to use aspirin in little kids, but go ahead. Feel free to use it in adults. One of the downsides, though, is it has a little bit shorter half-life than some of the other medicines we've talked about so far, but it works great. It works wonderfully. So remember aspirin. The dosing for ibuprofen and naproxen are here. Remember that there are max doses for both of those medicines. So as far as your nonsteroidals are concerned, they're max doses for those too. Now, if oral medicine is a problem, can you use the IV form of a nonsteroidal, which is ketorolac? And the reality is yes, but a couple things about it. There's something wrong with the drug when the oral dose is smaller than the IV dose because it's so toxic. The other thing to know about ketorolac is that 25% of patients won't respond to it when it's given IV. The IV dose has to be the IV and IM doses have to be very, very carefully chosen because of its significant toxicity. And there's no study that shows that giving it IM is any better than giving oral ibuprofen. So honestly, the place for ketorolac, its best use is IV in people with kidney stones or gallstones. And even then, about 25% of patients won't get a response. So it has a definite role, but it is not as broad as we tend to use this agent. And honestly, if you're giving IM ketorolac because you think you're treating pain wonderfully, you might want to give PO ibuprofen instead. Again, it's a little bit overrated of a drug. So then it has its issues. You've got to be careful with the dosing. So be a little careful with this, and you're not exactly getting what you think you get with ketorolac. Now, the real deal stuff are the opioids. And honestly, we have a panoply of them to choose from. Opioids, they are the best drugs for acute pain control. Please don't treat an acute fracture in somebody who's in a lot of pain with something ditzily like a nonsteroidal. Go for it, honest to goodness. And you have choices. The best agents for acute pain control are things like fentanyl, which we'll talk about in a second, morphine, and hydromorphone, which is Dilaudid. That's our sort of parenteral dosing. There are oral doses as well, but remember, acute painful conditions, sometimes oral's not good enough. And again, our job is to get on top of that pain, get it controlled, and then we can keep somebody with their pain controlled. Moderate pain is the oral stuff. It's the sort of the oxycodone, hydrocodone stuff. And I'll tell you, codeine, which has been around forever, okay, Tylenol number 4, Tylenol number 3, it's been around forever. When it's tested, when it's blindly tested in research, doesn't hold up very well as a pain medicine. In fact, it holds up quite poorly as a pain medicine. So codeine, there are certain patients who will respond, and I think that's fine. One of the things about our job is not to be sort of, I do it this way only, to understand that individuals are truly individual, and some patients may get a response. But in general, codeine is not a very good pain medicine. People don't respond terribly well to it. The same applies for medicines like Darvon. And I'll tell you, my pet peeve pain medicine right now is tramadol. Tramadol is a strange drug. Now, it works for some people. Again, if it works for them, great. But there's some problems with tramadol. We didn't put this on the slide. I'm just going to add it as an aside. But tramadol is being used a lot because it's not quite as much of a narcotic. Baloney. It is a narcotic, but it's a narcotic with a little bit of SSRI thrown in there. So what it does to grandma is makes her a little loopy if you give her tramadol. It's not safer at old people. In fact, it's probably less safe in old people to use this. In an overdose, it's horrendous. And when tested, it actually doesn't, when it's really, again, blindly tested against things like acetaminophen, it isn't a whole lot better. So you don't get a lot of bang for your buck for an expensive medicine that has a lot of side effects. Now, it doesn't mean you shouldn't use it. If it works for that patient or you feel that's the best choice for an individual, that's fine. Just know that in the literature, it doesn't pan out very well, to the point where they have now released it in a form that contains acetaminophen because acetaminophen works. Okay, acetaminophen is probably the more active factor in that thing. So know that our choices of pain medicines, honestly, for at least in the emergency department, are the parenteral forms like morphine, fentanyl, and hydromorphone, and the oral forms like oxycodone and hydroxycodone. Okay, those are the ones that you want to use primarily. Parenteral agents. Morphine is fantastic. Morphine, and you have to write out morphine sulfate. Your charting is really important. It can't be MS. They might do something wrong, so it has to be morphine sulfate. Remember a couple things about it. It's wonderful. It kicks in about 3 to 5 minutes, so it's not instant. It's going to take a little bit of time to work, but it lasts about 3 to 5 hours. That's wonderful. It has a nice long duration of action. Know that the effective dose is 0.1 per kilo. If you have an 80-kilo adult and you're giving 5 milligrams of morphine, you're underdosing. And we often underdose morphine. It comes in 5s and 10s, sometimes 4s and 8s, depends on what your formulation is, but we often underdose it. Please remember, if you really want to get on top of pain up front, give that slug of a dose. And in fact, the range of dosing is 0.1 to 0.2. So in that 80-kilo person, give them 10. It works great. So use the right dose. If you underdose it, they're unhappy, you're unhappy, it just doesn't work terribly well. Hydromorphone, which is what a lot of people use now, Dilaudid, know a couple things about that. It's great. It works wonderfully, but it is 5 times more potent than morphine. So your doses are smaller. We had a morphine shortage. What is with this drug shortage thing? Honest to goodness, what is with I was just talking to Billy in the back about this recent succinylcholine and etomidate shortage. What the heck is going on? For a while, we weren't able to get morphine. So we were using a lot of Dilaudid, but the residents were having trouble with the translation was sort of how much do I give, to the point where several overdoses occurred inadvertently because they weren't familiar with the dosing. No, it's 5 times more potent, so the dose is 5 times less. You're going to give a 0.5 milligram to 1 milligram. Getting up to 2 is getting, again, maybe good range, watch them, but you're not going to go to 3 to 4 routinely, not up front with Dilaudid. Now, fentanyl. Some emergency person died and went to heaven and said, God, I need a pain medicine that kicks in really fast, and I need a pain medicine that doesn't release histamine, which is what morphine does, which means that if they release histamine, they get hypotensive. I've got already a hypotensive person. I need something that doesn't do that. So God made fentanyl. Fentanyl kicks in 60 seconds. 60 seconds. If you have somebody in a lot of pain, that's wonderful. It doesn't cause histamine release. You have that multiply injured trauma patient, already you're a little bit worried about their blood pressure. It's less likely to cause a hemodynamic effect. That's great. The downside to fentanyl, it is 100 times, it is microgram dosing, not milligram dosing. And if you prescribe a lot of fentanyl, just know your doses. 50 to 100 micrograms for most adults is about right. You can always titrate up. And all 3 of these parenteral medicines, one of the major side effects is respiratory depression. So know that all 3 of these can cause respiratory depression. Just watch them. Okay, keep them on a monitor, watch them as you give them appropriate pain medicines to manage their pain. The best way to get at this is to use a good slug up front. Okay, morphine's 0.1 per kilo, give them 10, give a good slug up front, get their pain controlled, and then titrate doses on a relatively rapid and regular basis to get them comfortable and keep them there. That's the best way to use the parenteral opioids to get somebody's pain under control. Minimizes side effects, maximizes benefit, it's great. Adjuncts. I'm willing to bet that a lot of you in this room, because we did this forever and a day, will prescribe something like morphine plus X, morphine plus Phenergan, morphine plus Visceral. We were taught for a very long time, I was taught this in both of my residencies. I did 2 residencies, internal medicine and emergency medicine, and both of my residencies taught me to use them together, made the pain medicine better as an adjunct. It kind of ramped it up and decreased the side effects of the pain medicine itself, so it was a great thing. It turns out, when we finally studied that, and these studies are now about 10 years old, 10 to 15 years old, that doesn't work. What we think is happening isn't happening. What we are doing is adding some side effects, but we're not adding benefit. So a major change to your practice when you go home, if you're doing this, is to stop doing it. And if you're doing this because you want to take care of the nausea that's associated with some of the opioids that we give, go ahead and do it later. Most people don't develop the nausea. If they do, go ahead and treat it then. Doing it up front doesn't, again, make that pain medicine any better, and doesn't necessarily take care of the nausea in people that aren't going to get nausea. It just makes them hypotensive or altered. So be careful with these. It doesn't really work. It adds unnecessary cost and risk. So you can use these medicines if they're indicated, but you don't necessarily use them up front. And the literature is pretty clear on this, so it's something you can do to change your practice. How about oral opioids? Absolutely. Okay, oral opioids, they are often needed to control pain. You broke your leg. You're going home in a long leg cast or splint. You need some pain medicines for home. It's miserable. And often you need an opioid. That's somebody who's going to be miserable at home. So fractures, burns, really bad lacerations, those people need narcs at home. Please go ahead and give it to them. Make sure, though, anytime you're prescribing, this goes with that sort of risk management thing that Greg talked about earlier, anytime you're prescribing anything that could alter someone's sensorium, like a narcotic, make sure you write on the chart, do not drive, do not operate machinery, don't carry your baby, etc., and document that. Tell them and document that. Really important as far as your charting is concerned. Now, what can you use? Sort of 2 major drugs that we can use orally that work. Okay, remember, I already talked about codeine, not so great. Tramadol has its issues. Things like Darvon, Propoxyphene has its problems. Really, if you really want to be clearly sure that they're going to get some pain control, you're going to use something like hydrocodone, and that's the Norco, Lortab, Vicodin group. Or you're going to use oxycodone, which is the Perca group, Percocet, Percodan, Oxycontin, sort of the higher end group. Please feel free. Please feel free to prescribe these for people who need them. The dosing is there for you. Know that you have these narcotics available in oral form. Say you have an 8-year-old who has a supracondylar fracture. They're going to get seen by the orthopedist in their office. You want to send them home with something. That kid can get oral elixir narcotic. Okay, some of these are in elixir form. So feel free in children as well. As far as discharge is concerned, their pain is mild. They have a little bit of a burn on the back of their hand, no big deal. Go ahead and give them something like aspirin, give them acetaminophen, lower doses of nonsteroidals, or if it's an inflammatory condition, bump that dose of nonsteroidals. But if it's moderate to severe pain, please give them a narcotic to go. Okay, opioids. Little careful in older people. Okay, be a little careful with what kind of dosing you use. Fall risks are important. And then tell them things like elevating ice, that sort of thing as well. That's the narcotics, the drugs, the pain control. The other big batch of things that we do as far as drugs and the ED are concerned for this sort of deal is sedation. Now, a couple of things. Procedural sedation is a highly protocolized, very observed, very measured thing that we do in our hospitals. The Joint Commission gets involved, CMS gets involved, everybody gets involved in this stuff. You have to be very careful how you do this. Protocols are highly desirable. Sedation has to be done the same across your hospital. It can't be different in the ER, in the endoscopy suite, in the angio suite. It has to be the same across the entire hospital, which has made things a little difficult. A lot of decisions need to get made when it comes to procedural sedation. We do it a lot. Appropriately, we do it a lot. It's very important for procedural sedation for a lot of the things that we do in the ER, relocating shoulders and cardioverting people who are in unstable rhythms. Sedation is very important. However, it is a potential harm area. So these need to be very carefully done. Your choice of agent is important. Now, a couple things. First of all, it needs to be done in a highly monitored setting. A protocol is crucial. Your nursing staff has to monitor certain things, document certain things. You have to do the same. They have to be on different kinds of monitors, etc. Your choice of agent is very important. You're going to have to, and I'll tell you another thing about procedural sedation. Never do procedural sedation for your convenience only. My shift is over in 20 minutes. I want to relocate this shoulder. Yeah, the guy just had a big, super Gordo burrito and fries and a supersized something or other. But I'm out of here and I want to go. I'm going to do this for me. Don't ever do it that way. Never. Always do it with the balance, with the patient in mind. That person, that shoulder's not, it can sit there for another couple of hours while he digests. It's not urgent. That would be different than if you had an ankle dislocation with tenting of the skin and distal neurovascular compromise. Okay, that needs to be done right now. That's in the best interest of the patient, even if he just ate. So choose carefully who gets procedural sedation, because we can do a lot of harm with this. The drugs that you choose, you have to be equally careful, in fact, probably be more careful with these than you do with pain medicines, because they all have issues. You're going to have to choose what's appropriate for your individual patient. For instance, Midazolam is a commonly used sedative agent. If you had LASIK surgery, eye surgery, you probably got an oral dose. They gave you a pill of this to kind of get the edge off while you had your LASIK surgery. This works well, and one of the benefits to Midazolam when you use it for sedation IV is it's amnestic. They don't remember what you did to them. Okay, it's wonderful. I mean, think about it. You have some awful procedure done. It'd be nice not to remember. A couple things about it, though. It can cause respiratory depression. In and of itself, it's not a fabulous sedative agent in painful conditions. You have to add a pain medicine on top, like fentanyl, but now you've double whammied the risk of hypoventilation. Respiratory depression is a much higher risk on this. It does kick in quickly. It lasts about a half an hour. It's a very nice agent to use. It was used forever and a day as our only agent for a long time. It's fine, but we have better agents now than we did. Now, ketamine is magical. Ketamine is the weirdest flipping drug. It is a chemical pith. It's as if I went in there and just whacked you off and took your upper brain function and completely dissociated it from the fact that you are breathing and you have a blood pressure and a heart rate. Now the two don't talk to each other anymore. So you swallow, you maintain your blood pressure, you maintain your heart rate, but you don't care what's happening to you. You've all seen it, right? If you've used ketamine, you give somebody ketamine and they go, and they just stay there. You can put their arm up there. That's ketamine. It's the lights are on and nobody's home. That's what the drug does. It is an analgesic. It is amnestic. It's a profound dissociative sedative. Works wonderfully. It is great. However, it has some problems. Emergence is the biggest thing we've worried about, because if you see somebody come out of ketamine whacked out, it's really frightening. Adults tend to do this more than kids by far. People with psychiatric issues tend to do it more. You can treat that with something like Midazolam later. You don't need to do it up front. You don't have to add it to the concoction up front. If they develop emergence, you can do that later. They can hypersalivate. They can get laryngospasm. All of those can occur. Those are potential downsides. That being said, there is a huge body of experience with this drug. It's the most commonly used international anesthetic agent out there. Quite safe if you use it in the right person. There are certain contraindications. You can read them for yourselves. But this is a fabulous agent, particularly for things like suturing kids, that sort of thing. Wonderful agent. Now, Etomidate, which is the drug that we use to induce unconsciousness in people that we intubate, you can also use it as a sedative agent in a half dose. So the dose for this to sedate somebody is about half of what you use to induce them. So it's about 0.1 per kilo. It kicks in quick. It's gone in 5 to 10 minutes. It's deep sedation. They're gone. Sounds like it'd be a perfect agent to use. The problem for this when you use it for sedation is they get myoclonus. They get this really weird, almost seizure-like jerking, anywhere between 10 and 50% of the time. It makes things like relocation quite difficult, and it's proven to be, and when they come out of it, they tend to vomit. So that's not a great deal. That's not a wonderful thing. So how about something like Propofol? This is called the milk of amnesia. It is a bottle that looks like milk. It's creamy white in there. It is an instant deep sedative. It is the real deal. You go night-night and you are out, completely out. We jump right to deep sedation with this drug. It works quickly. It's wonderful. Doesn't last terribly long. That's all great. Couple problems with it, though. You can't use it if you have an allergy to soy or eggs because it's based in soy or eggs. Can't use it. You got to ask about that. And if somebody is hypovolemic or fragile, like an older person, our usual sedative dose will make you hypotensive. Okay, it can actually drop your blood pressure. So what we'd like to do is let's take a medicine that actually increases your blood pressure when we use it, like ketamine. Let's add it with a drug like Propofol and see if the two together work. There's a combination called Ketofol. It's a 50-50 mixture of ketamine and Propofol. You get the sedation that you get with ketamine, but you keep your blood pressure nice and normal. And that vomiting sometimes that you get with ketamine, I treat with Propofol, but the hypotension that I might get with Propofol, I fix with ketamine. Fantastic. So far, the literature is pretty good on this. A couple really big studies in kids, one good study in adults. Pretty good stuff out there. So Ketofol is something that's coming down the pike. So those are your agents. Know that sort of these are the drugs we have to choose from. Your goal is get on top of pain, keep it controlled, get them, sort of use your adjuncts, get them out on the appropriate medicines. With sedation, use it in the right setting. Never sedate just for your convenience. Do it for the patient in mind, and pick the right agent. Those are our drugs. That's our pain and analgesia talk.